with the increased costs of care associated with operations, look at Medicaid, it used to be roughly 64 cents on the dollar. It's like 42 cents on the dollar now. So like even cost-based reimbursement, and if that makes up like us 65% of our business, you're never going to be profitable, right? So you have to be really innovative, really thoughtful, really efficient, thinking outside the box constantly.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
This week on Power Supply, we speak with Shane McGuire, CEO at Columbia County Health System. And Garry, Shane's somebody that you know. This is your guest that you're bringing on. We're going to be talking about critical care access hospitals and delivering patient care to rural communities. And really, it's a challenge right now. And I can't wait for people to hear from Shane today.
It's a pleasure to have him on today. I've known Shane for quite a while, and I know he's integrated in that community. I've actually been on site and visited with him, and he's very, very intelligent and very smart and well-rounded on what he does. And so I'm just really excited to see what he has to say today, and I imagine he'll have a little bit of passion with him too. Very, very caring individual and a great leader. So looking forward to Shane's interview today.
He's got a big heart, and you're going to hear all about it next. Stay with us. After a short break, we'll be back with Shane McGuire, CEO at Columbia County Health System.
I'm Hayes Walder.
This is Garry Skinner.
And I'm Justin Poulin.
A production of 17 Studios. You're listening to Power Supply.
Joining us now is Shane McGuire, CEO at Columbia County Health System, and we're going to be talking about some differences and the nuances with critical care access hospitals in rural areas. And so, Shane, we're really excited to have you on, not only because of your experience in this area, but also as the CEO. I feel like these days, supply chain has more of a table or more of an audience at the C-level. And we really want to not only promote that, but I want to hear from you today as we kind of go through this conversation, like what is it that you need to know from supply chain that just helps the organization run better? So thanks so much for coming on.
Yeah, my pleasure. I appreciate being here. Thanks for the invite, and thanks for giving us an opportunity to talk about rural. Sometimes it's often overlooked, but we're covering 80% of the land mass, 20% of the population, but still I would say an integral part of healthcare in the US. So
well, what a challenge that is, the population density factor versus, the actual square mileage of geography. But before we even dive into that, Shane, can you just talk about maybe your career path and your way to, becoming the CEO at Columbia County?
Yeah, it's sort of a non-traditional path. Background is IT technology. And so spent some time, we call it the cloud now, but in the earlier days, it was really, data centers that were sitting on the backbone of the internet hosting applications. And a lot of the organizations that we were aligned with, the vertical we were in, a lot of it was medical. So hospitals, imaging centers, single radiologist couldn't cover 4 hospitals at night if he was jumping in his car every time he needed to read an image. And so he sits at home in his fuzzy slippers, right? And we bring the images to him. And so, you started learning the language and the dialogue And then in 2010, the EHR propagation, there was some funding from CMS to build out electronic health records in some of these rural hospitals. And I was already sort of aligned with a bunch of rural hospitals that all of a sudden had this chunk of money and had no technology and didn't know even where to start. And so I live in a small town. I live in Dayton. I was working for a technology company called 180 Networks at the time. And I remember like the pharmacist in town like pulls up in a cloud of smoke in front of my yard while I'm sitting on my deck. And he says, "Hey, Charlie talked to you yet?" And I'm like, "No, who's Charlie?" And so he's the CEO at the hospital. He's got a project. And so sure enough, Charlie pulls up in a cloud of dust and gets out of his car before it even starts moving or stops moving and asked me if I'd come in and be their administrator for their EHR deployment. And it was a great opportunity because I was a chief operating officer for 180 Networks and I was covering the Pacific Northwest. I was gone all the time. And the thought about, man, just playing with computers would be great. And so got in, started doing the work. But anybody who's operational quickly understands that it's not just the technology, right? It's that human interface and how it interfaces with day-to-day productivity, which, I'm just really strongly adept to that. And before I knew it, he had 8 departments under me and I was the director of operations. And
always how it rolls.
Yeah, that's the guy that does a good job. Gets promoted quickly.
Do a good job.
I'm terrible at saying no. So,
Shane, I have to ask, that word picture you gave us of pulling up and cloud of dust and getting out. Tell me more about Dayton. Just kind of give me
Dayton, Washington,
just give me a feel for what's Dayton. And other than yourself, what's famous there?
Yeah, famous the Green Giant, right? So, the ho Green Giant guy, well, he's like
really?
Plastered on the hill and everybody stops and points at him.
It's real. Yep.
Yeah, so the Green Giant plant was here for years. They used to process asparagus, stuff like that. But, it's roughly 800 square miles, population density of like 4.2 people per square mile, average age 50 years old, 28% of the population over 65. We're the second or third oldest in the number of people that are over 85. So I think Garfield County is like number 1. We're like number 2 or 3. And so aging population, traditional America, man, aging population.
Oh my gosh. Yeah. And Shane, just the closeness. I've seen you. I've been to Dayton, Washington. We've had some conversations out there. The closeness of everybody. You can't go down Main Street and have lunch without running into somebody, correct?
Oh yeah, dude. I patterned my life after you, though. To be honest with you, when we met in Lewiston,
well, you had me until that point.
Me throwing something at you or stopping us. Skinner. Oh God, here we go.
There it is. There it is. No, Shane knows everybody.
You were really impressive till that.
Oh gosh, Hayes. Here we go, Hayes. It
was tracking so well until you said.
Justin, keep him in line, please. Can we work this out, please?
Can you mute Garry, please?
This is pure entertainment. I'm not going to babysit this.
Oh, my God. You need to sit back and watch this, Justin. I need your help sometimes.
Good luck on that, buddy.
No, all seriousness, no, Shane, the community and the people that you serve in that area, you see them day in and day out, and it's great to be able to serve that local community. One of the things I was talking to Justin about before you came on was the ability of you to treat people in their own community versus having to drive 5 hours on an interstate. That's a big deal. I think that's something you strive for in your local area.
Yeah, absolutely. I have this philosophy that, CEOs that stay closer to the patients, their organizations deliver better care. Like if you're in a CEO tower in the West Wing and you're never running across patients and seeing them eye to eye, it's hard to keep connected to what you're doing. But here, it's your friends, your family, your neighbors. It's, people come over and say, "Hey, Jack's in the hospital. He'd love for you to come over and say hi." You don't really get that at larger institutions all the time. And it's something that brings a lot of value to me here. Keeps me really close to the population too. So.
And I admire that about you, honestly, Shane. I have a good friend of mine, Lee McCall, is a CEO of a critical access hospital down in Mississippi. And during the middle of the pandemic, during all the testing, protocols, going drive-through testing, he was literally using their boardroom and he was doing the testing just like everybody else. As if you don't have enough people working, you got to do the job.
Step up and do it.
I'm sure you did as well.
Yeah, direct traffic, somebody will be right out. It just kept you right there. And you can see the stress and anxiety in people's eyes. Like, early on it was rough. They were scared. Vulnerable population, when you think about it. We're right in that demographic that gets hit hard by, COVID. So.
Exactly.
So Shane, we talked a lot, kind of on the surface level of what's different between rural and community hospital settings versus large metropolitan health systems. But, obviously with your background, you probably served, all different kinds in your role prior to being at the health system. What were some of the unique challenges? I mean, you kind of even described like they had all this money for tech and didn't have any tech. And, that to me, I even think about some of those communities that they may not be as comfortable with tech as somebody in kind of a metropolitan area, right? And that could be untrue, but what are some of those differences, not only for the hospital and the health system, but things that create unique challenges for them just based on the community?
Yeah, I mean, it's sort of this concept of a limiting mindset, right? And that's the thing that I noticed that a lot of small rural hospitals get into is this, hey, we can't do that. We're too small. We're too little. We don't have the resources. We don't have the staff or people. I mean, I often joke when we're talking about like the code blue team, right? You'd be a doc that comes into our ER and you're calling a code blue. We'll look around because everybody's already in the room. It's not like there's going to be this whole crush of people that go running down the hallway and all of a sudden the
third
code blue
floor,
team's there.
fifth floor, down the stairs. No.
It's us. You may or may not have a respiratory therapist on the team, managing the airway, right? So sometimes the doc has to manage the airway, or the doc actually has to do some stuff that they wouldn't traditionally do in a larger facility. And I think everywhere you look in rural healthcare, there's this sort of resource deprivation that can do one of two things. It could either motivate you to figure out new and innovative ways of doing it, or it could be demotivating and say, well, we just can't because we don't have the resources. And I think that, what we're seeing sort of shake out nationally is some rural hospitals are grabbing a hold of that innovation ring and they're taking some risks, and some of them are just taking that stance. Well, let's see what the federal government does to us next year. That's a losing strategy in my mind at this point, because the house holds all the cards, if you will. And when you're already losing, like even cost-based, right? Cost-based doesn't actually cover all cost. People think that 100% of the cost of care is covered. It's approved costs. And, with sequestration, we were losing 2% on everything. So you lost 2 cents on every dollar of care. With the increased costs of care associated with operations, look at Medicaid, it used to be roughly 64 cents on the dollar. It's like 42 cents on the dollar now. So like even cost-based reimbursement, and if that makes up like us 65% of our business, you're never going to be profitable, right? So you have to be really innovative, really thoughtful, really efficient, thinking outside the box constantly, looking for other revenue options, grants, HRSA grants, participating in ACOs, shared savings. We're looking at a patchwork quilt of funding that's keeping this place moving forward. So
yeah, Shane, how do you get there? I mean, you kind of touched on it a little bit. Is it at statewide meetings? Is it watching what the government is supporting? You're staying tight to this, but how do you find those avenues to dive into and then implement them accordingly so you can't stay in the black and not worry about the funding coming down the pike to support?
Yeah, I think the first thing is really looking at your community and what do they need, right? Because that's going to drive the passion. That's going to drive the motivation, right? And so for us, like, let's just take our wound care program. Columbia County Health System has a hyperbaric-based wound care program. Okay. We're partnered with Healogics. We've got 2 hyperbaric chambers. And from the get-go, we knew day one that there was no way there was enough population in Columbia County that had wounds that would make any sense. But we also recognized there was no hyperbaric chambers or high-quality wound care in Walla Walla. People drive all the time for healthcare. I mean, you go to your specialist cardiologist, the guy you got to see is in the Tri-Cities, that's 90 minutes away or whatever. It's a 35-minute drive. And we thought, well, what if we just built this, started marketing it in the surrounding areas and became the wound care center for the region? And so, if you're in Dayton and you're a Dayton resident and you've got a diabetic ulcer on your foot, guess what? You got world-class wound care here. You got up to even hyperbaric treatments, but it's really servicing 85%, 90% of people outside the area. So referrals from other providers. So
that's fantastic. And so how close is that nearest larger system, that you would refer to and or that pulls from your community?
Yeah. So the surrounding areas, a lot of them are Providence-based health systems. St. Mary's out of Walla Walla, 35, 40 minutes away. They don't have a hyperbaric-based wound care program, so they're doing more traditional debridement and that type of thing, whereas we're doing those biomeshes and the bioskins and wound vacs that are advanced wound vacs, that type of thing. The next closest hyperbaric chamber is in Kennewick, which is, an hour and a half away. And then I think there's one in Tri-State, which is in the Clarkston area, which again is, an hour and a half away. So,
and Shane, let's set the tone for the listeners at home. We're not talking about jumping on an interstate and a 4-lane highway.
Yeah.
Let's be realistic what the winter looks like and the roads that we're traversing trying to get to those locations. It's coming this way and going this way. I mean, and it's a lot of farming. Go ahead, Shane. Yeah.
Yeah. Well, patient compliance is one of the biggest things about wound care. I mean, you have 5 days a week. So you're traveling to whatever wound care center you can get to 5 days a week for treatments. And if you start missing hyperbaric treatments, we're not getting an oxygen level enough in your blood to actually affect the wound in a positive manner. You're not going to heal timely. And so that's part of the goal, is to keep the treatments really close to home.
And I'm going to jump on this bandwagon a little bit about mission, about the conversations we've been having on the podcast, and I'm sure Hayes outside and Justin as well, is we're in this crisis mode a little bit now with all this labor pool and what we're trying to take care of our service lines and take care of people staying home. That is the biggest deal. And as we lose that, people have to keep going further and further and further away. And just don't want to see that. Want to keep the mission, want to keep the patients close. Like Shane can go into a room and go, Jack, good to see you here. How you doing today? And that's the closeness. That's what gives me the goosebumps. I mean, I talk about mission all the time. These guys they agree with me, but they know I'm going to bring it up. I'm always about the patient-centered, focused mentality, and you can't go wrong there all day long. We got to keep it. The money will come. We got to keep it. So, sorry, just jumping off that one.
I appreciate that sentiment, man, because it's a big deal. I mean, for us, mission, vision, and values, but then leadership philosophies and how those leadership philosophies tie back into the mission, vision, and values. It's not, our whole concept was when we put those things together, I don't know how many places you walk past the mission and vision statements. They're like on the wall and they're dusty. And, how do you make it a document that people are paying attention to? And it's part of our new employee orientation, as an example. We refer to it every time, and we try to find those key ties to the care we're delivering, those things that sort of pull your heartstrings a little bit when you talk about a community member you helped out, and how that brings that back to your leadership principles and the mission and vision.
Shane, you mentioned that, even just onboarding new employees and things. And obviously one of the challenges that many, many hospitals are having, obviously everywhere, is hiring good people, finding good people, staffing RNs, PTs, RTs, whatever. In a place where you live, how hard is it to find quality people? And is that an issue?
Yeah, there's something like 6,500 open nursing positions in Washington State. Washington State does not participate in the National Nurse Compact, so we don't recognize licenses outside of state like a lot of other states do. There's like 38 states that recognize nursing licensure, but Washington, Oregon, and California are not participants in that. And so we're already sort of challenged from a supply perspective. Culture, man. Culture's king. Like, healthcare has become a meat grinder. It's become a meat grinder for the patients, and it's become a meat grinder for the people working in the system. We've lost, in my mind, we've lost a little bit of compassion. We've got compassion fatigue, if you will. And so in 2021, we started doing some intensive culture work, organizational development. Like, this is at a time when people are already tanked, right? It's 2021. We're just got through the first year of the pandemic. And we're going to do this extra huge, massive thing. We brought some people in, some just incredibly talented, skilled, motivational folks that really dug into what a high-performing culture looks like. And we saw it start resonating with the team here. And they started talking. The nursing's a tribe. Like the nurses at your hospital talk to the nurses at the hospital down the road, and they all went to school together, and word of mouth. And so we are not necessarily in the same position that a lot of our peers are. We're very fortunate. We were hiring at a time when most people were losing nurses. We have contract nurses on staff, but I've heard rumor that some hospitals are 70% shift contract nurse. We're not that. We carry 4 or 5 contract nurses to help fill in, but a lot of it is our nurses bootstrapping for the organization they love. And I got to tell you, it's inspiring.
And they're connected to the community.
It's inspiring.
Right? Like, when you talk about culture, do you feel like it's easier to create that culture in that rural area where people feel just a greater connection to their community. Like, here's what I'm thinking about. Like, I am a nurse, Shane, and you're absolutely right. It's an insiders club in a lot of ways, and they lost me to podcasting. So I'll tell you, it's just one of those things. The burnout rate is high. Like, I started when I was 19 doing personal care, and by the time I graduated from college, I already knew I was borderline burnout. And I wasn't sure that that's what I wanted to do. And so that meat grinder comment really resonates with me, even long before the Affordable Care Act, which I want to get to next, because there's a specific provision of that I think was not kind to the rural health systems. And so, but I wanted to ask you, do you think that it's easier? Because I'm just thinking about during the pandemic, it's kind of like nurses felt like, I can't walk away from this right now, because what's my community going to do? And I feel like in other settings, it's like, I'm scared, rightfully so. And I feel like I'm going into harm's way and I'm going to take a step back. And I'm not saying that everybody did that, but if you're in that aging population, the high risk group, nobody knows what's going to happen. You don't have the PPE to provide the care. That's especially at the early stage, that's a pretty big risk for nurses to be taking. And I think everybody was well aware of that.
Yeah. I mean, heroic, really. I mean, over and over again we saw it, but what's happened since then is, I don't know what to say. The patients themselves have gotten just almost abusive of their teams and the staff. There used to be this intrinsic value that, that concept, hey, you don't pay me enough to do this job. Firefighters running into burning buildings, police officers running to the sound of gunfire. Like, that's not a payment thing, right? That's a value alignment. And I really do feel that nurses were in that same category, that respect, that thanking of the nurses for taking care of me or taking care of my husband, that really balanced a lot of the stress from the job, right? That sort of fueled a lot of people's tanks. That's been hard to come by. I think, COVID and everything about it, the staff shortages, the high bed rates, all of those things have created these stressors for everybody involved. And I just don't think that a value equation is what it used to be. We use the word burnout. Dude, it's not burnout anymore. It's injury. It's just these nurses are wounded.
Take.
They are wounded emotionally. It isn't burnout. We've just got to find a way to stop hurting them. We've got to find a way to support them in a different way. And we've got to be that executive team that's there, like actively talking to them. What can I do? How can I help? We have this joke, nurses love pizza. They don't. Nurses hate pizza. Like, stop buying them pizza, for God's sake. There's got to be better ways. And not to say that we figured it all out, but really, really looking for ways to try to make it better. I went into a meeting with our nurse supervisors one time and just opened myself up to what I thought was going to be like, I was like dreading it, man. I had a hole in my stomach for a couple days going into it. But I sat there and asked some questions and just shut up and listened, took notes, and really, really came away with some action items that could better support them. Taking away some of those things that cause daily injury. Like, one of the things that came up is, hey, did you know that the computer system rebooted at 2 a.m. and it could be down anywhere from 15 minutes to 45 minutes. And I'm always in the middle of a note or middle of a med pass when it goes under, and then I don't know when it's going to come back. If you knew it was going to do that every one of your shifts, like, dude, that's a pebble in your pocket. Like, by the end of your shift, you're walking around with your pockets full of rocks, I mean, how could it not, wear on you? So, taking away some of those injuries is been our first goal.
So I want to go to that Affordable Care Act piece, right? Because, long before the pandemic, the Affordable Care Act hit rural hospitals. And so, in a lot of cases, what we saw was the larger health systems and the aggregation movement, right? But you'd still have to be fairly near a metropolitan area for that to happen in a lot of scenarios. And it's really around what happens when somebody's readmitted with a surgical site infection, and then you have to cover the cost. And I guess my concern is kind of related to what Garry was saying. Like, they might have to drive a long way, but if they drive a long way after they've had a procedure and something comes up, and it could just be, lack of home care and teaching and education about how to dress the wound. Like, it might have nothing to do with the actual procedure itself, the reason that there's an infection, right? And the next thing you know, they're out of town, they're out of network, and you're footing the bill at metropolitan prices. at Metropolitan Premiums. How did that impact your supply chain, the way you looked at, HCAP scores, the way you looked at just everything that came out of that? And how does it still affect you? I'm sure it's still a struggle to some extent.
Thank you for asking that question. One of the things about critical access hospital designation was sort of a recognition that the critical access hospitals take care of an older, sicker population. Critical access hospitals most of the time exist in home health shortage areas. And so there was an exemption that was put in place that exempts critical access hospitals from high readmission rate reimbursement penalties. This is one of those areas where critical access hospital designation and small ends, if your numbers are so small, they don't penalize you. Like, this is like a different situation for us. Our HCAPs, even though we do them, we feel they're very valuable feedback. If you go to the Hospital Compare website and you look us up, it's just a blank number because the end's so low that they don't even publish it, right? So we have some protection from some of that other hospitals don't necessarily get to enjoy. And it is literally because of those small numbers. We don't get penalized for readmissions here. We strongly, because of now ACO savings and shared savings and population health management, we're pursuing that anyway. Like, nobody wants readmissions, right? And we work really closely with our local area partners. We do consider Providence a wonderful partner. We exchange patients with them all the time. We take hard to place patients from them, and we want to be good stewards against readmission as well. Because if we don't do a good job here, they will get penalized for readmission, and we don't want that to be on our watch, right? We don't want Providence to say, God, don't send them to Dayton. We're going to get readmissions for sepsis or whatever because they're not doing protocols. So, that's sort of how we play the game. It's sort of on the back side of it. The opposite side of it is, how can we be a good steward to prevent our other partners, our larger partners, from having readmissions? Home health, though, that is a problem in rural. Like, first of all, in Washington State, certificate of need. So that's like $75,000, and attorneys and time. There's not enough volume, and they don't reimburse it. It's not a cost-based reimburse. It's a carve-out. Essentially, if we did it, it would become a carve-out on our cost-based reimbursement. So it has absolutely no financial benefit. The home health agency for Columbia County, the certificate of need is actually held with Providence in Walla Walla, which is 40 miles away. So if you look at the same beneficiaries, Medicare beneficiaries, home health utilization in Walla Walla's benchmark for the state, it's like half of benchmark in Columbia County. It's the same provider. Distance away from the home health center means lower utilization. So these people are going home after serious events. They have no home health support at all. And what's happening is they're coming into our ER, they're coming into our hospital because of that. Infections, site infections, wounds, you name it, unable to thrive at home. They don't have a nurse, they don't have support systems. It is a huge challenge in rural America. It's a huge challenge here in the state of Washington.
Yeah. Early in my nursing career, it was home health in, rural areas of Maine. So I remember those environments and I remember that challenge. And that's kind of why I brought up wound care specifically and those readmissions, just related to lack of support, effective support structures out there in the community like that. I've seen it. I kind of want to pivot a little bit more, focusing on supply chain, your experience as a CEO, and what you kind of want to hear or what you need to know from supply chain. And specifically, I want to start, though, with the fact that, just listening to your background and having that IT experience, I got to think you have like this programmatic mind. You almost see everything as a workflow map
Swim
in your
lanes.
head. You must visualize that whiteboard with the boxes and the arrows. And,
causal loop diagrams.
Kind of comes back around.
Positive feedback,
Right.
negative feedback. Skinner's in the middle of it.
No.
Yes, Hayes. Yes.
No wonder this is
So
a complicated.
the reason I asked that or tee it up that way is because I think that experience actually makes you really adept at understanding supply chain, especially as you had to get involved,
Yeah.
I'm certain, more than you would have before over the last few years.
No leverage, man. Rural had no leverage during the supply chain disruptions. When they put you on allocation, like if you're only ordering 2 boxes of something ever because you're already a small number and they put you on allocation, like, are you going to give me a quarter of a box? Like, what does that even mean?
Yeah.
And so it really,
A partial gown.
right.
Yeah.
Here's one of the
Just a
2 slippers
drawstring.
you need for your feet,
Here's the back portion.
Right. Yeah. It was miserable. And really, from a pandemic perspective, we really relied on, partner organizations like WISHA, our local emergency management folks, some very, very like radar type people from MASH. I'm dating myself. I've got enough gray in my beard, but people that could like make stakes show up in the middle of a war zone. That's exactly the type of people that we were dealing with on our end. And, we were able to scrounge masks. Some of them were terrible. Some of them were like, you opened them up and the things broke off immediately. They were obviously just sham masks. We were one of the hospitals that ended up with some of those fake 3M masks. It was a challenge all the way around. I have to tell you, medication, pharmaceuticals, that's another one that just burns me. Like, shortage in things that you absolutely positively have to have, like fluids. First of all, we got this merger and acquisition thing that's happened. So there's only a few producers of the product anyway. Some of them are offshore and in zones that are susceptible to extreme weather that take out their ability to create it. And it is literally the base product that you use to put the medication in, right? It's the saline, it's the fluid. And then you start getting these calls, right? How do these, first of all, I don't even know where these guys get a number, but it's like, hey, I got a van parked under I-5 and he's got boxes of fluid for you. You only have to pay 30 times more than what you normally would pay for them. You know what I mean? And so those things have been the ones that have been really challenging for us because we have to resource the organization. We have to resource the service line. So now we're looking at it differently. Like this really was an eye-opening experience. And so there is this sort of concept of, hey, we know that just-in-time inventory burned a lot of people in a lot of organizations. We streamlined our inventories to the point where they were working great as long as the supply chain was whole, but it's not anymore. And so now we're really thinking about, where do we store it? Like, how do we make sure that of the necessary things that we always have some sort of base inventory available, even if we know that it might be waste at some point in time? The supply chain is no longer dependable. So, yeah, that's where we're at right now.
Yeah, and Shane, I was just going to bring it on to where you're at. It's everybody's responsibility. How do you view it at your level on supply chain and products? Everybody's got to be in the know, correct? I mean, and we're talking about everything from, you brought up the glass syringes that, shortage. You talk about all the things that come down the list of any distributor, any GPO. It keeps coming down the pike of, we're out, we don't have any raw materials, there's a shortage, and then the whole allocation you brought up. Whose responsibility on the floor is it? It's across the board, isn't it? It's everybody.
Yeah, I mean, in rural, it's a little tough because, in the bigger organizations, you have these material management committees, right? Where, vendors come in, they present their product, the committee looks at it, and they select something. Because we don't have that here. And then for a while, you have 5 docs and they all wanted a different suture. We had 5 different sutures on the shelf, right? We had to realize that also was not efficient or effective. We had to start standardizing products, and we had to start talking a little bit more about it. And so we have a materials manager, Chris Davis. We have facility managers over him, but more importantly, like, we're really engaging med staff and the nurses now to, first of all, standardize product and then create par levels within their departments. It's materials management, 9 to 5, right? So what happens after hours? How do you manage that inventory when it's coming out the door at 2 a.m? We've had to build a lot more infrastructure around it. The computer system that we have is not helpful at all. It's not directly attached to vendors. Like, some folks have these really robust computer systems where, oh, look, it dropped below par level, automatically issues a PO, sends that PO off to the vendor. And no, that's not how it is here. So.
Well, Shane, first of all, huge congratulations. I'm amazed about not only your understanding of everything you're doing. You did a great job explaining it, number one. But 2, obviously, the last couple of years have been tough. But leave us with a minute or 2 of just, why do you get up every day to go do your job? What's fun about your job? Tell me something good about it.
Yeah, we've had a commitment to pushing healthcare outside of the 4 walls of the organization for quite a while. Like, we're no longer just standing by the door waiting for patients to pull up in the parking lot. We built a palliative care program. It was the first outpatient palliative care program in the region. Providence doesn't even have it. And so we started taking care of people in their homes, man. And so we've got 2 nurses out there. We've got community health workers. We have turned lives around that these people were slipping through the cracks in a bad way. You know what I mean? And they have chronic disease, and they have multiple providers. They have medication cabinets that are just stuffed full of medication from the last 4 or 5 years of their life. We got a pharmacist comes in the house now. We've reduced inpatient admissions in that population by 45%, and we reduced ER utilization 60% for that palliative care population. And so, and some of these people, like, they're just crying. Like, I can't believe you're doing this for me. I can't believe you helped. I mean, because you engaged, I got to keep my kids. I mean, some of it's like at that level where CPS is involved in the house, and we help stabilize healthcare. We help make sure that they're aligned with resources in the community, that they're signed up for those resources, and they get to keep their kids. Like, it's just powerful. And so those are the things that keep me coming in and listening to the stories from those nurses on the effects and impacts they're having. It's incredible, And so we're looking for other programs like that. Other programs that get us out of our chairs into the home. And by the way, when you do that, it's like Pandora's box, right? Because then you really realize and recognize the scope of the problem. It's not just about the wound anymore.
Nope.
Yep.
Well said. And then obviously your passion just exudes in this conversation. So thank you so much for doing this.
Yeah, it's my pleasure.
That was Shane McGuire, CEO at Columbia County Health System. And honestly, Hayes, the thing that stood out to me, especially as we were wrapping up that interview, he said somewhere along the way about culture is king. But man, you got to have a big heart right now with, the way he's leading that vision and looking at the purpose of serving that community. And we talked about this after we hung up. But Hayes, I mean, I recently, maybe just a day ago, saw the numbers of CEOs leaving healthcare, and it's scary. And it speaks a lot to, what Shane was just talking about, the way he was viewing nurses. I think CEOs are going through the same thing. Anybody in healthcare is going through the same thing.
I would totally agree with you, and it's much like college football coaches, right? It takes years to get a culture. It takes years to get your own team there. And if they're churning them so quickly, it's hard to create a culture that he's done, which is so impressive what he talked about. I mean, not only before our interview and after the interview, his passion for what he does is tremendous. Great job, great guy. I would work for him today. So I really enjoyed it. I learned a lot.
I'd say his passion almost kicked up another, notch when he wasn't being recorded. And I thought he was pretty darn passionate while we were doing the interview.
He was fantastic. And again, the challenges of rural healthcare is absolutely at an all-time high. And he's doing a great job there in his community. I guarantee you they love him there.
Yep, someone to emulate. All right, well, that's going to do it for this show. But just a reminder, the best way to follow or listen to Power Supply is to download our smartphone app for iPhone or Android. And you can go in there, you can find bonus content, you can search past episodes and topics you might be interested in. But if you're not going to download the smartphone app, you can definitely find us on Apple, Amazon, or Google Podcasts. We're also on Stitcher, iHeartRadio, and Spotify. And if you're using another podcast application and that's your favorite, just search for Power Supply over there as well. While you're there downloading the smartphone app, though, we'd certainly appreciate a rating and a review because your feedback's important to the show. And if you do have feedback for us, like a suggestion for a future guest or a topic or just general feedback on how we're doing with the show, just send an email to info@powersupplymedia.net. On behalf of Hayes, Garry, and myself, thanks for listening to this week's episode of Power Supply.